So I'm going to be because we're short on time, I'm going to kind of just focus on one case and kind of throw it out there to you both and have a discussion. Hopefully that we can get some questions from the audience too regarding hopefully some things that we see pretty commonly. And then hopefully Lisa can give us some lived experience perspectives from some of the patients that she's worked with. And Stephanie will definitely speak about the role of pharmacy in primary care because pharmacists do provide primary care and we need to kind of reiterate that role for them on the team. So the first case and the main case we'll talk about today is a 58-year-old patient. He has obesity, he has hypertension, he has longstanding type 2 diabetes, and he ultimately did get a FibroScan at one of the community events. And his metabolic clinic scan showed F3 fibrosis. Okay. His AST and his ALT, though, were normal, and he feels entirely well. So he's completely shocked by this result, and he's confused because he has no liver symptoms, quote unquote, just some mild fatigue. So I'll start off just by saying that you should not be reassured by normal AST and ALT because it can actually be a sign of burnout of the liver when a patient flips from inflammation over to advanced fibrosis, right? When the liver gets really burnt out, those AST and ALT numbers can actually normalize. And I think that's really important thing for somebody in primary care to realize that people can have cirrhosis actually and have pretty normal liver enzymes. So that is something that should not be reassuring, but something that you should still take seriously. So on the clinical side, that's a point that I wanted to make. But I'm curious, Lisa, in terms of patients that you've seen with a similar story that get this diagnosis, what kind of emotions or fears do they typically experience when they get this diagnosis?
Yeah, and I think this is something that we hear from our community often when we're talking about people who live with obesity. We know it is very common for them to also have other comorbidities. And I can reflect on this as a personal moment as well as somebody who has navigated obesity care. I've had gastric sleeve surgery and I've used pharmacotherapy support for over 10 years now. And in the last 2 years, I was also diagnosed with MASH. So it was another moment where it felt like, oh, I've done so much and I've tried so hard. And really, what I know the frontline treatments that you're about to say are all things that I've already crossed off my list, and I'm maintaining an over 100-pound weight loss. And it's a very, it's an overwhelming feeling, or it was for me, I can say from my personal experience, because it just feels like what's left for me to do in this moment. But
Mhm.
luckily, I have fantastic supports around me, and I had a doctor who could see the hard work that I've put in and said, and worked with me in a way to reframe that from being a moment of feeling desperate and there are no hopeful options in front of me to we can do this together and you're doing a lot right. Let's focus on the good and let's double down on those efforts and at least maintain where we are today. And that was very reassuring for me as well after years of kind of trying to unnavigate diet culture and learn the right world that I want to be in, and to feel like I didn't need to go back to those harsh kind of all or none kind of thinking that we heard about a little bit earlier today as well. So I know that's my personal experience, and I know from our community what we hear is definitely we already feel like a problem, and we have been a problem our whole lives, and now we're just another problem that still doesn't feel like it has a clean answer. Is often the first line that people have in their heads. But I'm so grateful to see so many fantastic people here, and I know we can change their narrative here as well.
Love that. Thank you for sharing your personal story. I've been so amazed by the personal stories that people have shared. And I know, in my clinical experience that so many people feel normal, right? And have this diagnosis. And we need to meet them where they are in that, right? Because we're concerned about them and we're laying this heavy information on them and they're not quite there yet, right? Their brain is still trying to catch up. And I think using that person first language that you mentioned is really important.
Yes.
Um, but in this case specifically, this patient has F3 fibrosis, right? So if we're assuming that this FibroScan was accurate and we want to believe that F3 fibrosis is really there, it's really time to focus on some of those pharmacotherapies in conjunction with that lifestyle treatment. So I'm curious to hear Stephanie's perspective on what kind of therapies we should be considering in this patient. And then also would love to hear the perspective of maybe what has been your experience as a pharmacist working with patients like the one in this case.
Yeah, thanks, Melina. So I think before we jump into pharmacotherapy, we all just need to remember that lifestyle modifications are very key for patients, like we've heard in other sessions, but also setting very realistic and clear guidelines for patients, which we've also heard. Just telling a patient, oh, do 150 minutes of cardiovascular activity per week. I know I wouldn't do that. So breaking that down into kind of a bite-sized piece is helpful, and especially in people who've never been very active in their life, even just telling them, start with 5 minutes, start with 10 minutes, and just slowly build that. Same with diet piece, meeting people where they're at. So if somebody's a shift worker, maybe talk about meal prep. Give them solutions like 10-minute dinners, point them in that direction instead of just being, oh, eat healthy. Um, but in terms of drug therapy, pharmacists across the country as well as in the US definitely will have different scopes of practice. In Alberta, pharmacists can prescribe and initiate therapies. So really using your whole team as a resource for the patient to get them started on drugs early. I personally, in this patient, would try to get them on a GLP-1 or tirzepatide right away. But often our biggest hurdle is going to be insurance companies and what they choose that the patient wants covered. So knowing that most companies, you do have to start with metformin for a period of 3 to 6 months for anything else to be covered, at least get that ball rolling really, really quickly. In this patient, I would love them to be on both a GLP-1 and SGLT2 eventually, but again, it's just going to be what is financially possible for the patient as well as what's covered.
Right. And I think that's where interdisciplinary care really comes into play too, because I frequently am referred patients who, their insurance doesn't cover a GLP-1, but they want alternative obesity pharmacotherapy. So I talk to them about their comorbidities. Do you have anxiety or depression? Do you have migraines? Like, are there other, weight loss medications? Because believe it or not, there are other ones besides GLP-1s, even though we've all shifted to really focus on those. Like, might they benefit from bupropion or Wellbutrin? Might they benefit from Contrave or something like that? There are other options, right? So that's where that interdisciplinary care comes into place, because a hepatologist usually is not comfortable in prescribing those medications. A primary care may or may not be, usually is, but it really depends on the person.
Yeah.
Lisa, with your diagnosis and with your patient's diagnosis in your work with Obesity Canada, did you work with an interdisciplinary team? Did you work directly just with your primary care and hepatologist?
I would not be able to navigate life without an interdisciplinary team. And that is so reflected as well in our clinical practice guidelines at Obesity Canada. And I was also really grateful. I had the opportunity to go to the UN General Assembly meetings and to hear right from the WHO and the UN level saying we need to start looking at people in silos and look at the whole person and move from those verticals to the horizontal is so fantastic, because we know the answer for all chronic disease, quite frankly, is this interdisciplinary kind of care and getting this wraparound support that we really need. We need a once in a generation kind of rethink of how our teams are operating and what we're setting up for success, because we know that if we do this in the right order of events and we get out of our way with paperwork and our own kind of bureaucracy, we can probably have some pretty impressive health impacts more quickly than not, quite frankly. We spend a lot of time jumping these hoops, but I won't go too deep into that because I know we feel that pain together. But I'm also hopeful for the future, and that there's a lot on the horizon to be excited about, and that there's a lot of us having really great conversations on that even policy level to try and make this better for people. But could not say enough that yes, you need more than one. This is not, we can't prescribe our way out of this, and it's not about finding one hero clinician. It's really about connecting the
Right.
dots.
Yeah.
We all have our strengths, right? And I think it's really important to be humble enough as a primary care doctor, as an endocrinologist, as a hepatologist, as a pharmacist, to know, like, I actually don't know, right? And I really found it powerful when one of the patient advocates mentioned that their hepatologist is like, I don't know, like, I think it takes a really good doctor to say that. And I think if more of us felt comfortable saying, I don't know, that would also foster interdisciplinary care. On the flip side, though, sometimes there are gaps in communication, right? And that's part of the problem between the different doctors and how we communicate. Have either of you had an experience where maybe it went the opposite way, in your personal or team experience?
Lisa, did you want to go?
Yeah, I mean,
Mhm.
I've experienced the gamut, if I'm really honest with you as well. So I've had fantastic moments where like it just feels like the burden is off of your shoulders when you get in those right rooms, and that, you know, I've had that clinician reach over, grab my hand, and be like, I'm going to get you to slow down and realize, remember,
Mhm.
this isn't all your fault, and that we're in this together. And that was like such a crazy, amazing moment compared to some of those moments that I'd experienced earlier in life, where it was really about shame and really very off-putting, almost feeling like you didn't want to deal with me as a person because of what you associate with obesity. And what I've learned today, just listening from some of the other speakers as well, and gave me a very much a new perspective and appreciation for people living with these liver complications, because it is the same. We get that judgment about those behaviors that people assume that we're making. And that really, we need to remember with all of this, I say it often in my world, weight is not a behavior, and a chronic disease is not a behavior either. This is something that is much bigger than all of that. And the more that we can relieve that pressure for the person, the more we know that as patients, we will show up and we will lean in and we will dial into our healthcare as well. And when we focus on health and not weight as well, that's another huge moment and opportunity for all of us, which is why I often say we need that space and grace to update our thinking and our practices, and recognize that when we know better, we do better, and science should evolve, and we should be blown away by what science can do and not be frustrated that it created more work for us.
I would say one bit of feedback that I've just seen from patients and just in my own practice is that they often get very conflicting information from different specialists. I think sometimes we forget that a lot of these patients will also have diabetes, they'll have hypertension, they'll have dyslipidemia. They're being told by one person to do a low carb diet, another low salt, low fat, high protein. Like that's just very, very overwhelming for a lot of patients. And I feel that primary care can really put all of those puzzles together and help the patient kind of make a realistic stepwise plan to achieve their holistic health goals.
If I can add on that a little bit, Stephanie, I love what you said there, because I think that's a huge part. I know I've personally experienced this. I've heard this in our community, and I can see it happening in other chronic disease communities as well. When you're navigating the world and you're living with a complexity like this, you actually get a little detached from your own self. And what we need to also remind patients is they are the best knowledge of their own bodies and their own lived experience. And we need to encourage them to make that reconnection with themselves and to be able to use their voice in those moments too. I know it can be challenging on the flip side to feel like, oh, okay, Dr. Google's in my office today. Someone did some research and their chat GPT gave me something that they want me to say to their doctor. But somewhere in the middle, I think, is where we need to kind of find each other and be a little bit, remind people that they are the best stewards of their own lives as well, and invite them in that way to show up and use their voice. And that can be a hard road for some people who feel really beat down by the system as well.
Absolutely. And I think there's a comment in the chat, about making a plug for some clinical studies as a way to get patients in to get access to care that they might not otherwise be able to get through insurance. And I think that is such an important point. We have patients at our institution that they would never get something like semaglutide, right? But Novo is sponsoring a study and we're, enrolling them actively and they're seeing improvement and they've lost 100 pounds and this and that. And so I think that's a really meaningful way to also take advantage of the barriers that we have. I do want to be mindful of time and make sure that if there are any questions directed towards Lisa or Stephanie or myself, that we're able to answer them. Otherwise, I'll also kind of give the opportunity to Lisa and Stephanie to give kind of more of a, this is what I want to leave you with. This is what I want you all to know on the primary care side from my perspective.
I just,
One thing,
can I ask a quick question? Sorry, and
Yeah.
I think it's so important for primary care. One of the things that highlight somebody gave to me that I thought really resonated is the most underutilized person in the healthcare team is our community pharmacists, that they have more touch time with our patients than we do. So, Stephanie, for those of my colleagues who are listening that say, how the heck do I go about working with my community pharmacist? What kinds of advice can you give?
honestly, pop in and strike up a conversation. And obviously, doing everything all at once is not going to end well. But choosing kind of one therapeutic area to work with, such as this, maybe doing a little debrief together and talking about how you can mutually educate your patients who are at risk for MASLD to get screened and empower them to have that discussion with their care provider, and vice versa. If that physician finds a patient who has MASLD, referring them to the pharmacist for further education. Start small.
No, I like that. It's really all about relationships.
Very
Um,
much.
and I think that from a primary care perspective, when we're working in interdisciplinary teams, one of the skills we have to develop is the skill of passing the halo, of being able to open the door to encourage patients to talk to your pharmacist, who can give you even more information about this than I can. And I think it really helps that handoff and increases that trust that patients see that we have in working in teams. So thanks for that, Stephanie.
Yeah, and like the passing the halo thing is huge. We are all on the same team, and that's team patient, and it's not about territories or anything. We're all here to help the patient. So I like that you said that.
Enough work for all of us.
Absolutely.
I also want to make a plug on that note, for those institutions or practices that have access to community health workers. That can also kind of be the intertying force between all of us. And for clinical diabetes educators, right? A lot of these patients have diabetes, and the reality is even I, as an endocrinologist, I don't have the time in a diabetes visit when I'm going through the liver and the microalbumin and the retinopathy and all of these things to go through the actual education component. And that is so critical. And I think we really need to take advantage of of those opportunities.
Give a little shout out there as well. We have a certified bariatric educator program for at Obesity Canada as well, which is fantastic. We just had an exam and I think we graduated a whole new pile of people. So I'm so thrilled we're getting more CBEs out there, because you're absolutely right. Those CDEs and the CBEs, the more that we can connect them together or introduce people to them, I think we could make such a huge impact. I also know I love, shout out to my local Lennon Drugs. I have a CBE pharmacist at my Lennon Drugs, and I can tell the difference of kind of how he has clinical spots to be able to meet with people and help connect these dots as well, because we know we're people, we're multi-complex people, right? So we're not just one single note, and it's great to feel like they're safe spaces to be able to go and have those kinds of conversations. And I could not agree more. I adore pharmacists, and that was even before I met you, Stephanie. But yes,
Oh, I think
huge fan of pharmacists out there.
I've also seen a push, and this is at least in the US, I don't know if it's the same in Canada, where a major kind of institution will have their own specialty pharmacies now. So, for example, like my hospital, even if I order it to a CVS, it automatically gets queued through our specialty pharmacy. So our clinical pharmacists are the ones doing all the prior auths and the approvals and communicating with the patient. So it's much easier to interface with them because they're leaving notes in the chart, and I can reach out to them directly, instead of, a faceless or nameless person who's working at a community pharmacy that I might otherwise not interface with. So I think there's definitely more of a push for that. Obviously, there's some financial incentives on the side of the institutions for doing that, but nevertheless, I do think it does help the patient.
I would say fundamentally at the end of the day, it's about the relationship between all the primary care individuals and specialists.
Right.
That's really what's going to make the difference in this era of misinformation and the swirl that we have around us. And I worry about the transactional nature of some pharmaceutical moments that are happening out there right now. And I really do think that anything to do with something that you're putting in your body that is a serious medication shouldn't be a transaction. It should be a bit more of a relationship moment as well. So again, why I love my pharmacists.
I want to pull in Shelley's comment from the chat, which I think is just so important. And that is, we'd be remiss if we didn't acknowledge the role of our mental health professionals in dealing with patients managing chronic disease, health crises, holistic and trauma-informed care. Shelley, thanks so much for bringing that to the table, because the biggest barrier that I see in my practice to self-care are those mental health challenges. Lisa, I'd be interested in And sorry, I don't mean to take over, but Lisa, I would be interested to hear your thoughts on that.
No, that
I'll shut up
it's
after that.
it's so foundational and it's so true. And when we look at our the clinical practice guidelines for obesity, the first chapter is about bias and stigma, and really that could be the mental health chapter as well, because we know that when people navigate the world and they're wrapped around and they just constantly get the feedback on that bias and stigma, it has such an impact on our mental health. And that mental health stigma burden really does impact physical health. We know that to be true now more than ever, and that's also why we need to show up for all of you guys, all of these healthcare professionals, whatever field you're in, to help with the competencies of how to have these kinds of conversations as well. And that's a huge component of all of this. So, and I really, it's as simple as kind of what we were taught from the Green Giant and all these people. Like, let's be nice to each other. Life is hard enough. Let's slow down, look people in the eye, and treat each other with the kind of dignity and respect that we'd like to be treated with, or at a minimum, how I'd like you to treat my grandma is how I want you to talk to me. Those kinds of moments. Let's just be kind to
Mhm.
each other and take a breath sometimes.
The last thing I also wanted to mention is, even though the foundation is lifestyle and pharmacotherapy, that's what I do in my clinical practice as an endocrinologist, we're still grossly under referring for bariatric surgery. And that's something that I think hasn't been brought up yet today. And I think critically important, right? Bariatric surgery still is the most effective, especially at certain BMIs, right? Pharmacotherapy has revolutionized everything, right? And I think that should always be offered to patients, but we should also offer them bariatric surgery if they need it. And I think that is something, especially for patients with, MASLD and MASH, that we can't forget.
It blows my mind how quickly things can respond once you've had your gastric surgeries as well. Like the instant response from your body is phenomenal. So thank you for shouting that out as well, because
Mhm.
absolutely we know there are multiple pillar options, and that yes, these pharmacotherapy solutions are going to help reduce some of that burden, which means we should see surgery wait times move a little quicker, those kinds of things as well. And if we can kind of look at it all together as a piece, playing together, I think it can make a big difference, because it absolutely is the right course for many people.
Right.
Melina, for those primary care physicians who are listening, I think we've been sort of so focused on the GLPs as our treatment for primary treatment for obesity. So, what kind of patient would you say to us? Look, here's a patient that you want to be top of mind to refer to bariatrics in conjunction with the medical therapies and lifestyle that you consider.
Yeah. I mean, I have patients who they've tried the lifestyle, they've tried the GLPs, and they're still having resistance, right? Everybody responds to pharmacotherapy in different ways. So those people that have resistance, that have plateaus, and they still have a significant amount of weight to lose, and they still have those comorbidities, of course, I always consider in those patients. But if I have a patient who has a starting waist circumference or a very elevated BMI, like I have some patients BMI 42, 43, right? Um, Pharmacotherapy should be offered and should help actually bridge them to something like bariatric surgery. But those patients really would benefit most from bariatric surgery, in my opinion, after a risk-benefit discussion. So, in my opinion, I think about degree of elevation of BMI. We know BMI is not the best measure, but in the reality, that's a lot of what we use, slash waist circumference. And then are they having resistance to weight loss with pharmacotherapy?
Would you prioritize those patients that do have MASLD as sort of fitting into those people you would maybe want to think about bariatric surgery as a even greater priority?
Yes, definitely. And the reality is too, bariatric surgeons, they want you to lose weight before bariatric surgery too, right? I'm sure that was Lisa's experience. That's one of the pillars of qualifying for bariatric surgery. So they're still going to end up on these medications, I'm sure. And they do. And it makes for a safer surgery and more, less knee pain to do the exercise that you need to do the weight loss. But all of that considered, it doesn't mean that we kick the can down the road and never offer them bariatric surgery. I think that's all I have, though. I want to make sure that we have time for Q&A from the rest of the panelists and the hosts of the sessions as well. So I'll let Rick kind of take over from here.
Yeah, just looking at the chat, and if people did have some final thoughts or questions, really appreciate the dialogue that we've had. And sorry to jump in there, guys, but the discussion was so rich that I couldn't sit on the sideline, so didn't mean to insert myself in, but
Oh, we
uh,
love it.
just a great panel, and appreciated the dialogues.